could leave. You can leave. Go ahead. Go through there. I'll cut that out.
Oh, okay, cool.
Good morning, students. Once again, coming to you from Naples, Florida, where it's very sunny out. And today I'll be covering the chapter on anxiety. That would be chapter 23. Okay, so let's jump right into it. Anxiety. What is anxiety? Well, basically, when we talk about anxiety, what we're saying is that you're feeling anxious or distressed about something. Maybe a loved one of yours hasn't arrived home yet, or maybe you're anxious about walking down a quiet road where there's no one around. Okay, so basically, it's a sense of psychological distress where you worry or you're uneasy about something. Now, is anxiety normal? Yes, it's a normal response. But when anxiety becomes chronic, pervasive, when it starts to engulf your life to a degree where you can't work or you have problems in relationships, then we have a problem then with, now you have a disorder. Okay, basically that's what I'm trying to say. Now, it's different from stress. Stress is just tension that you receive. Maybe you're stressed about taking an exam. You're stressed about work, school. That's kind of different. And then everybody's perception of stress is different. I may get stressed out about sitting in a car waiting for traffic to move, whereas some people will just sit there and they'll be relaxed and no problem. Okay, so it's really individualized, but stress and anxiety are different to a great extent, and we're going to see how. Next slide. Okay, this is slide 3. The fight or flight syndrome, you understand it. Heart rate goes up, pulse goes up, and usually when we feel anxious, this is what occurs, all right? When you have severe anxiety, it occurs to a larger degree, okay? You might perspire, etc. Next slide. Moving on to slide 5, the effects of anxiety. All right, so anxiety could be mild, it could be moderate, it could be severe, or you can go into panic mode. Now, mild anxiety is typically understood to be okay. We don't really have a problem with mild anxiety. You have a heightened sense of awareness. You have some improvements in cognitive functioning. However, in moderate anxiety, now you're going to have a little bit more difficulty with cognitive functioning, maybe a little bit with problem solving. You could lose your train of thought, and you might have... Basically, that's it. Okay, then when you get to severe anxiety, now you're definitely having problems with problem solving, cognitive functioning. You may have some motor tremors. You may start pacing or wringing your hands. And you're uncertain about things, okay? So, and then of course in panic, now you probably can't even speak. You feel like you're choking and you don't know what's happening. Your heart, you feel like you're having a heart attack or something, okay? So those are the categories of anxiety, okay? Let's go to slide 6. All right, so an anxiety disorder, as we said before, is when the anxiety is pervasive. It's all the way to the core of your human psyche, okay? it's been going on like that for a while, so it becomes chronic. All right, and your coping mechanisms have failed. You can't seem to cope with it. All right, so that's another point. Another point is that it's an unrealistic fear or dread that something's going to happen, some kind of danger. No actual danger exists, but something dangerous is going to occur, and yet you don't know what it is. So it interferes with your daily life, with relationships, your job, social functioning. So then when you have that, you have a problem. You have an anxiety disorder. That's where how we categorize that. Okay. Slide 8. Anxiety that requires intervention. Again, when you reach that phase in the anxiety level where you can hardly think, you can't problem solve, your coping skills are not effective, all right, and basically in the context of the anxiety, for example, someone who gets anxious about here's a contextual picture I'm going to give you. Somebody who gets anxious, let's say you're anxious about mice. You can't see a mouse because then you get anxious, okay? But now that anxiety is carried over to daily life, daily living, and you're thinking you're going to see a mouse while you're watching TV, and you're looking around to see if there's a mouse crawling around. Now you start obsessing about seeing a mouse. You have an anxiety disorder now. You're thinking the mouse is going to come, you're going to see the mouse, etc. So now it's in your daily life, and seeing a mouse shouldn't really affect people to that grade of an intensity, but you are being affected by those thoughts about the mouse, or even seeing a mouse. It affects you that much. All right, so we said it affects professional, personal, and social roles, right? And then you have flashbacks, you're obsessing about the mouse, and it lasts longer than it really should for a stress situation. Now, if I see a mouse and I get anxious, and I go, oh, mouse, and then I kind of, run away or whatever, but then I go on with my life, and that's it. But if now I'm kind of still carrying that anxiety with me throughout the day, then you have a problem. And that anxiety remembers despite any real threat, any danger. Now, the possible causes of anxiety disorders. Well, it's believed that the amygdala is the fear center. That's where a lot of emotions like anger and fear are generated, in the amygdala. So the amygdala, along with the hippocampus, which stores memories, work together. And when you see a mouse, the memories clicked in the mouse, that you're anxious about the mouse for some reason, then you're going to connect it. The image of the mouse connects with fear, which the amygdala will generate. The two of them work together. Anytime you see a mouse, the amygdala will kick in fear. Okay? So that's how the amygdala basically processes sensory input. Okay? And that sensory input will be converted into feelings of fear. Oops, I think I went too far. All right, so as we were talking about in slide 10, we gets a little more into it. The amygdala sensory information is processed and sent out to other components of the nervous system. If it interprets input as threatening, responses in the other regions lead to the flight or fight response, the behavior reaction, your pacing, your tremors, you have difficulty speaking. And then we have emotional experience of fear and anxiety. Excuse me a minute. That was good. All right, guys, back. Slide 11. Symptoms of generalized anxiety disorder. This is GAD, Okay, so in GAD you have chronic signs of severe anxiety. You worry, you're apprehensive, um, you have motor tension, autonomic hyperactivity, which is the sympathetic system kicking in, and you're hypervigilant. Okay, more days than not for at least 6 months. It has to be for at least 6 months. More days than not. More days than not would be 3 months and 1 day. Okay, you're unable to concentrate and you get fatigued and you have difficulty sleeping. You may have difficulty eating also. You're anxious, so it's a generalized anxiety disorder. Now, generally for all anxiety disorders, what we're going to do a CBC, right? We're going to do a chem panel, thyroid function, urinalysis, urine drug screen. What are we looking for? Well, we want to rule out other conditions. Like what? Well, we want to rule out substance abuse, okay? Maybe a withdrawal from a substance. Um, we want to rule out asthma sometimes, or any acute atrial fibrillation when the heart is just beating, and tachycardia. Person may feel like they're having a heart attack, so you want to rule that out too, okay? Or thyroid dysfunction. Um, let's look at symptoms of panic attack. Now, as I said before, in panic attack, the symptoms are that you're going to sense maybe a choking sensation. You feel like you're having a heart attack. You'll have palpitations, chest pain even. So in order for it to be a panic attack, you should have if you're following me in slide 13, you should have four out of the 13 here symptoms, okay? 4 of these. You feel like you're dying, sweating, nausea, vomiting, etc. So that would be a panic attack. Cognitive functioning is gone, problem solving is gone in a panic attack. Let's look at phobias, types of phobias. First one that's mentioned is agoraphobia, and that's fear of the marketplace. It basically, what you're afraid of is that you're not going to be able to escape once you get out into the marketplace, wherever it is. If you're in a train, in a bus, even out kind of in the open, that there'll be so many people around and you won't be able to escape, okay? Different from claustrophobia. They have a lot of similarities, but it's different because in claustrophobia you feel like your fear of enclosed places, okay, but in agoraphobia you're fearing any area where you might not be able to escape, okay. So in a sense it's different. Of course, in a claustrophobic confined spot, being in an elevator, inside a refrigerator, in a revolving door, that's basic claustrophobia. Agoraphobia is that you cannot go out at all because you're afraid that you're not going to be able to escape. The person with claustrophobia will be able to go out, but they won't be able to get, for example, inside of an elevator. Maybe afraid of going into a store because there might, in a dressing room, for example, in a dressing room in a department store, they won't want to go in there, okay? Social phobias. Now, social phobias, what are they? Well, that's basically fear of being put in a situation where you would be criticized or evaluated by someone. For example, public speaking. That would be a social phobia. Being out there in front of people speaking, they're going to evaluate you, then you're going to have a little problem with that, okay? So you feel people are going to criticize you. Specific phobias. Specific phobias are just irrational fears or avoidances of certain things, okay? So you might have, for example, arachnophobia. What is arachnophobia? It's fear of spiders. Okay, claustrophobia, fear of confined places. And we mentioned, cynophobia is fear of dogs. Elurophobia, fear of cats. Necrophobia is fear of dead things, anything dead, anything related to dead things, bodies, body bags, funerals, coffins, anything that brings you to mind of dead things, tombstones, cemeteries. That's that. Now, specific phobias are all other phobias except agoraphobia and social phobia. Take out agoraphobia and social phobia, then you have specific phobias. There's a whole list, just minus those. You don't really have to know that. If you have an idea of what the phobias are, then that's okay. Now, usually for phobias that are, for example, cynophobias, more specific phobias, cynophobia, fear of dogs, fear of snakes. We have fear of snakes, for example. Let me just get this one. Ophidiophobia. Ophidiophobia. That's fear of snakes. Okay, so let's say you have ophidiophobia. What we'll do is we'll put you through a process of desensitization and exposure treatment. Okay, so in desensitization is basically a classical conditioning technique by which a patient learns to confront and replace gradually the panic response with the relaxation response. Okay, so in desensitization, what you're going to have the patient do is some maybe covert rehearsal. Covert rehearsal is where that patient is going to sit there, or that person is going to sit there, and they're going to see themselves in the situation. For example, they're going to close their eyes and imagine that someone's bringing to them a snake. And how are they responding to this snake? To seeing the snake? Very relaxed, very calm. And so that's the picture that they're going to be looking at. And then they're going to just try to relax, bring down their blood pressure and pulse. Okay? Now, in desensitization, hopefully that patient is going to confront the snake, but is going to relax. So before, let's say if I have you in the room, you're sitting here in the room, sitting in a chair, and I haven't come in yet. I have the snake with me. You're sitting in the room. You're going to go to a happy place. You're going to imagine yourself in a happy place. You can even imagine yourself seeing a snake and feeling very comfortable seeing the snake. And you can see yourself petting the snake, and there's no problem, and you're relaxed, okay? So now I'm going to come in. You're going to imagine yourself doing these things, and then I'm going to come in with the snake, and you'll stand at the door, and you're going to see the snake, and you're going to be relaxed. And then I'm going to walk back out. Then I'm going to come back in, maybe take a few steps into the room, and you're now again going to see the snake. And then I'm going to walk back out. Then I'm going to gradually come in again, maybe stay a little bit longer, and you're relaxing, etc. And so this is done for maybe for an hour. I'll keep going back out, come back in for a little more time, a minute, 2 minutes, 5 minutes, 10 minutes, and I'll stay in the room, and then eventually until the stimulation of the visual stimulation of the snake wears off. Okay? Now, in exposure treatment, it's a little different. Similar to desensitization, but it doesn't involve the relaxation or gradual approach. I'm just going to bring in the snake. You're sitting there, and all the doors will be locked. you'll see the snake and you'll scream and carry on, and you'll run into a corner and you'll sob and cry, and we'll just stay there. Man, we'll just stay there. And eventually, you know what? You'll stop crying and sobbing and you'll get over it. And that's exposure treatment. All right, moving on to slide 17, obsessive compulsive disorder. So in slide 17 rather, obsessive compulsive disorder, not to be confused with excessive compulsive personality disorder. There's two distinct. But when we think about obsessive compulsive, we think about obsession. What is an obsession? Well, obsession is when you constantly have a thought or an impulse, an image, an idea keeps coming to your head. That's an obsession. You can't stop thinking about it. All right? For example, an obsession that your hands are filled with germs. Every time you go out, you come back, your hands are filled with germs. You're getting germs all over you. So you don't want to touch anything that has germs. I guess now in these times, we probably are becoming a little obsessive about germs because of COVID-19. We're constantly washing our hands. We clean our doorknobs. Everything is clean. You don't want to touch anybody. It's a little bit different, but we are getting obsessed with it. Now, if it starts affecting our lives, then we really have a problem. Okay, so that's an obsession. What's a compulsion? A compulsion is a ritualistic behavior. It's a behavior that you do over and over again. I constantly wash my hands because I believe that there are germs on it. And these germs, usually the obsession is a thought that is repulsive. It just it makes you want to puke. You don't like it. You want to try to get away from it, so you do something to avoid it. Like washing your hands. So you wash your hands, and this decreases the anxiety that you receive when you get these thoughts in your head, because you're becoming anxious over the thoughts and the ideas. So now you wash your hands and then you feel a little better, okay? And basically that is OCD in a nutshell. Next slide, 18. Let's look at stress disorders. First one is acute stress disorder. After that, we have post-traumatic stress disorder, and then we have the different ones, post-traumatic stress disorder, chronic post-traumatic stress disorder, and then we have delayed post-traumatic stress disorder. So first we'll look at acute stress disorder. All right, so something happens, right, to you, something which is unfortunate and should never have happened. Maybe you witnessed a murder. Maybe you were robbed. Maybe you were raped. Something happened. You were physically assaulted. You almost died in a car accident. Okay, so these are stressful things that happen. So within a month, right, within about a month's time, you experience symptoms, okay? Maybe anxiety, you're still anxious about the whole experience. You see the images, you walk around kind of like in a daze, your dream-like state, and you get flashbacks, and you might be a little fearful over things. If it was, if you got robbed, maybe if you see a gun or hear a gun, you get afraid. In combat, some soldiers, they hear gunshots and they jump because they've seen, it reminds them of the experience that they had. Okay? So you respond with fear, helplessness, and horror. Okay, so let's look at next slide. Slide 18, types of stress disorder. Slide 19, types of stress disorder continued. I already talked about acute stress disorder. Now I'm going to talk about acute post-traumatic stress disorder. So after a month, you're still having the same symptoms. You can't get away from them. You have nightmares, you have flashbacks, etc., sleep disturbance. It becomes acute stress disorder. It becomes chronic after 3 months. If it continues into 3 months, now it's chronic. All right? So those are the three primal ones that we're going to look at, that we looked at rather. And then we have delayed PTSD is nothing, you're okay, and then after 6 months, about 6 months, you start having symptoms. That's called delayed PTSD. Some people have that also. All right, so what do we do for anxiety disorders? What is the treatment? Well, psychopharmacologically, we can use selective serotonin reuptake inhibitors. Why? Because they're pretty safe and they work. All right, and they don't cause orthostatic hypotension. No anticholinergic effects like when we use antipsychotics or whatever, and they don't really have a sedative effect. So these are the first line drugs, right, that we use, the SSRIs like Prozac, Zoloft, and Paxil. There are also benzodiazepines that we can use. But we know that with benzodiazepines, we're at risk because these patients might overdose. They might commit suicide with these benzodiazepines because they suppress the central nervous system. And so they're also physically dependent, and they have a high potential for abuse. People start abusing them. And if you suddenly stop taking them, you could have withdrawal symptoms. If you use benzos with alcohol, then you could potentiate the effects of the benzodiazepines, which won't be good either. You could have CNS depression and you might die. All right. So another drug that's used is buspirone. Buspirone is good because it's not really a sedative, it's not addictive, and so it's used for anxiety. The only problem is that it takes 1 to 2 weeks before the buspirone becomes effective. We can also use beta blockers. Propranolol is also a good one, especially if the person has cardiovascular problems. They're less effective, but they do work. But if the patient is going to be on propranolol for an extended period of time, you should not discontinue them abruptly. Propranolol. Side effects of using propranolol are depression, nightmares, bradycardia, and hypertension. TCAs are also used. Proven effective against generalized anxiety disorder in patients without comorbid major depression. And desired outcomes in slide 22, you could look at that. And 23, desired outcomes and treatments, you could look at that. And I just want to thank you for participating, and I hope you got something out of this. If you need to ask any questions, feel free. Ask me on Canvas or in Outlook. Okay, thank you so much. Bye now.